Medical College, Professor Sebastian Polak, who is a leading expert in biopharmacy. Professor Polak's team, research team at the Faculty of Pharmacy, focuses on in silico modeling and simulation methods for drug development. But I must stress that beyond academia, Professor Polak also is a senior scientific advisor at Certara UK, where he has played a key role in advancing computational approaches to drug safety, and especially the development of cardiac safety stimulator, a huge achievement. And Professor Polak research is transforming how we assess drug safety using predictive modeling to improve both drug development and regulatory decision making. I must stress that Professor Polak's work really bridges cutting-edge science with real-world impact. Now he's actively involved in the VITAL project, and a very ambitious initiative in drug-human twin modeling, which exemplifies his forward-thinking approach. And this project, by integrating real patient data and advanced computational techniques, is paving the way for really more personalized, sex-specific and precise medical therapies. So we are very, very fortunate to have him here today, and I really look forward for his seminar. So the floor is yours.
Hi, Carolina. Thank you so much. And hello, everybody. It's great to see you, and thank you for joining. Just a quick warning before I start. As you have probably noticed, there are two cats in the house. Normally, they're taking a nap, well-deserved rest after 10 hours of sleeping, but you know, with the cats, you never know, everything can happen. So sorry about that, and sorry in advance. They can just jump, you know, all over here. So once again, sorry. All right, as Karina said, I'm wearing two hats at the same time. So apart from working at the university, I do work for the company as well. Most of the material which I'm going to present today has been actually generated as the latter, which means Certara. So that's why there is a logo there. So what I'm going to talk about is how to try at least to predict CNS exposure for xenobiotics. But what the hell has Bach in common with that? That's probably the question which we should start with. So there is this song which I like a lot, which was written by Zbigniew Wodecki, one of the Polish songwriters and singers. He passed away a couple of years ago, unfortunately. And this song came to my mind when Karolina approached me and asked about the lecture, and the title was supposed to be somehow connected with the brain or braining, or something what is connected with this area of science and our understanding of the world. And there are actually two elements which I think drew me to this direction. So the first one is, I'm pretty sure that apart from Carolina, there are some other groups and scientists right now listening, which are involved in the drug development, and this drug development is focused on the brain. So our aim is to deliver the drug to the brain and to make them work there. And probably the most important element which you are working on or testing is affinity to your target of interest, which is perfectly fine. However, I'm afraid sometimes we forget that we have to deliver this drug to the brain to make it work. And we do not necessarily have to start with something very complex like target optimization or structure optimization to hit the target. Maybe apart from that, we should start with something slightly simpler, which is pharmacokinetics, and to think how to deliver the drug to the brain. That's exactly what I'm going to talk about. So that's the first one. And if you notice, the last line of this song is someone who should enter, but maybe not. It's exactly the case of the drugs which we want to deliver to the brain. We do want it to enter the brain. However, we do want to control it as well. So maybe it's not necessarily always, you know, everything should go there. So that's something what we are going to discuss today, or touch upon at least. Apologies, I will start with like a repeating of obviousness. I'm pretty sure you know all of that. But again, just to create a background understanding, I will start with that anyway. So I'll go very quickly through PBPK, differences between different distributions or mechanism of distributions of drugs, what are transporters, what is partitioning. I won't touch on enzymes. I don't think we need it for this lecture. However, I'll mention it quickly in one or second place. And then I will very quickly discuss something what you probably know much better than I do. And you know much more about it than I do, which is the difference between BBB and BCSFB, so what it is and why we should discuss them both and not forget about them both at the same time. So what is PBPK? So PBPK is about pharmacokinetics, or briefly speaking, physiologically based pharmacokinetics. So what we do, apart from using simple or relatively simple empirical models to describe drug concentration in the body, we do focus on the physiology. There is a hands up. I don't know whether there is a question or it was a mistake. Please stop me whenever there is a question. So the hand is not raised any longer, so I just go. This PB at the beginning means we do focus on the physiology. So we do provide, apart from the information about the drug, information about physiological parameters like information volumes, blood flow, composition, and so forth and so on. There's hundreds of them really, and all of them gives us the ability to say that these models are mechanistic in nature. So we do use it's a mechanistic understanding of the tissue and the distribution of drug in the tissues to be able to predict and describe how do they distribute in the body. But we cannot forget about the drugs, obviously. So that's something what we do have to provide. It's part of the parameterization of the model. Beginning from relatively simple physicochemical parameters to information about the ADME, so how the drug is metabolized, what is stuff into transporters, and so forth and so on. It all together is kind of a deep in the source of something what we call trial design. So how often the drug is given, what is the dose, whether the drug is given with water, without water, is it given orally, intravenously, and so forth and so on. So all of that is described as trial design. And these three pillars build PBPK. So we've got information about the drug, about the system. In this case, the system is human body, and the trial design, so everything else, environmental parameters, if you like. Obviously, behind this, more or less, nice cartoons, there are mathematical equations. I'm not going to go to the mathematical equations. I will maybe show one or two, or present one or two, but that's pretty much it. But just, you know, trust me, there is math behind all of that. The second thing is something what you probably know very well, differences between perfusion and permeability, and how these two phenomena, physical phenomena, in fact, influence drug distribution in the body. So what we're interested in from, let's say, kinetics point of view is what are the rate limiting steps or rate limiting phenomena which occur during the drug distribution in the body. The first one which comes to our mind and should come to our mind is the blood flow. Why? Because the drug is caught by the blood and transported everywhere in the body. And in most cases, I hesitated, but still, in most cases, blood flow is a rate limiting factor. The first, let's say, factor which you're interested in is blood flow. And in such a case, the bottleneck is the amount of blood which flows through certain tissue. An example of such a tissue can be adipose or muscle. Why? Because there is not so many, it's not very much of an abundance when it comes to the transporters. So proteins which are involved in the active transport of the drug. However, some other tissues, kidney, lung, brain, liver, gut, all of them have quite a lot of transporters. And actually, it's not any longer perfusion limited, it's permeability limited, because the permeation is limited or can be increased or speed up by the presence of transporters, which actively throw the drug molecule on one or the other side of the membrane. So in our case, the answer for the question which of these two phenomena or approaches we have to follow when we think about the brain is obviously permeability limited, because there are active transporters there. Just one thing here, and again, I'm not going into the details. we do have to understand one thing. So as long as passive diffusion means we do follow the drug concentration gradients, for the transporters, it can be the opposite. So we have lower concentration and still the drug can be transported to the other side. So it's against the passive permeation approach or phenomena. And at the same time, and please note, it is important, I'll come back to that later on, the same transporter can transport drug or xenobiotic in both directions. And only one of the, say, side is active, can catch a molecule and throw it on the other side of the semi-permeable membrane. Sometimes it can be the same transporter, depending how it is located and how it's changing its conformation. It can work as an influx or efflux transporter. It is an important message. Okay, what are the key transporters in the brain? And that's something what I'm going to spend a bit of time. There's plenty of them, and that's something what we do have to consider when we are thinking about building a model, which is supposed to predict or help us to assess the exposure of xenobiotics in the brain. And actually, here is yet another thing which I'm going to discuss. There are differences between the blood-brain barrier and the blood CSF or CS fluids barrier. Not necessarily only when it comes to the histological differences, but when it comes to the presence and abundance of transporters. Even if the transporters are the same in case of, or in terms of the structure and sometimes activity, the abundance will be different. So the amount of protein, physical amount of protein will be different in these two type of barriers. So we do have to distinguish between them. And that's something what will have its reflection in the PPK model, which I'm going to discuss later on. As you will probably notice, the transporters can work in both directions. They can throw the drugs inside endothelial cells and outside then endothelial cells to the blood, to the lumen of the blood vessels. So again, depending on the transporter, depending on the affinity of our drug to the transporter, it can be thrown away from the cell or transported towards the cell. Again, that's something what we have to remember, and we have to focus on that as well. So what is the message here actually? And that's something what we're going to exploit later on. There are in fact two barriers which protect the brain from the xenobiotics to penetrate this tissue. It's a blood-brain barrier and blood CSF barrier. Sometimes we say that we say blood-brain barrier and we understand everything behind that, but that's not necessarily true. It's something what we have to remember about. I mentioned abundance, and that's something what we will need to parameterize our model, and that's something what is measured, well, ex vivo to be precise, not necessarily in vitro. And the message is, and the information is, and the good news is, for us modelers, we do have this kind of data. So here is the list of some example transporters. You will probably know all of them, and abundance in the brain tissue. So what you will see is a amount of transporter per milligram of membrane protein. How do we do that? We dissect microvessels, and we use proteomics in most cases to quantify what is the amount of certain proteins in this subtissue, if you like. So some of them can be really abundant, and depending on the affinity of our drug or drug candidate or xenobiotic, poison, toxin, whatever, the activity will be different. We'll come back to that. There's one thing which I want to draw your attention to. There's this letter or this combination of letters ET here. It's not about those, alien from outer world. It's about the phenotype, and that's something what is really important. Depending on the phenotype, which is obviously described by the genotype, which each and every of us carry, we can have different abundance of transporters. So most likely the affinity of our drug to the transporter will be the same, regardless of the phenotype, but the abundance will be different. So instead of 100 units of something, we'll have like 10 units or 200 units. So instead of extensive transporting individual, will be poor transporting individual, or ultra rapid transporting individual. So with that, the exposure, even after the same dose, even after the same say environmental condition, will be different. That's something what we have to account for, and that's something what has its reflection in the model and mathematical description of the say brain disposition. How to measure affinity, because that's something what I mentioned several times. There's plethora of methods. The last time when I was in the lab, it was like almost 30 years ago. So I'm a pure, let's say, modeler, well, sort of at the moment. So I know that theoretical background, and I think I do understand it, but I've never done that myself. So if you have any questions about it, go to Carolina. She'll tell you everything about it. It's not me. There's plethora of methods. Probably the simplest one is oil filtration method. So you've got two phases, oil phase, water phase. You're just spinning it, mixing it. You can have hepatocytes there. You can have brain cells. You can have whatever you want, or some naive cells, which are transporter enzyme naive cells, which you can heterologously transfect with the transporter of interest. And you're just measuring what is the, let's say, concentration or abundance of the drug in two separate phases and separately in the cells. But that's just a half of the story. We're in the middle of the way, actually, because this raw data is not that easy to analyze. So in most cases, we do mathematical models. Even if we sometimes do not realize that we do that, we do that. We use mathematical models to understand this data. And what do we have here? It's a simple, very simple model, which describes, in this case, active uptake in hepatocytes, but it can be done for the brain tissues. It can be done for the microvessels. It can be done for whatever you want, as long as you have this kind of data from your lab. And you use two compartmental model of this in vitro system. So we've got internal part of the cell, or something inside the cell and outside of the cell. And we've got two type of, say, parameters: system parameters, like number of cells in this case, and drug-related or xenobiotic-related parameters. So what we have here is clearance passive, which means the drug can passively diffuse through the membrane. We've got concentration on both sides of the membrane, in the medium and inside the cell. That's something what we measure along the experiments. And we've got Jmax Km, which are the parameters which you know very well. It's a Michaelis-Menten or parameters which we use to describe the Michaelis-Menten type of kinetics. We do know the number of cells. It's our system, so we do know what we use in the lab. What do we do with the rest of the parameters? We measure concentration. How does that change in time? So this S is a concentration of a substrate outside the cell and inside the cell, and the rest is optimized. So we optimize passive diffusion clearance, which gives us the information about what is the affinity of the drug to the membrane, so how much of the drug will go through the membrane. And Jmax Km, which can give us the information about the affinity or speed of the transport for drug of interest across the membrane. In this case, we focused on one transporter. It can be whatever what gives you uptake, so influx of the drug, but it can be whatever you want. It can be efflux, it can be combination of transporters. It's probably not the best idea, because it will give us a pretty blurred picture. So what do we have at the end of this experiment, both in vitro and in silico, which you can see here? We've got information about the passive clearance, and we've got information about the affinity of our drug or drug candidates to the transporter of interest. Let's say it's an uptake transporter, BCRP or whatever, which takes the drug from the outside and transport it to the inside or internal part of the cell. Okay, we scratch the surface. We're at the in vitro level or ex vivo level, if you like. What then? Then we have to take a huge step to the in vivo level, because even if we do know the clearance, total clearance, which means how effectively this drug or drug candidate is cleared from the medium, which mimics the extracellular space in the body, and taken to the internal part, inside to the cell, we're still at the in vitro level. So we are supposed to take it to the in vivo level. This slide is very busy and super unfriendly. I'm sorry about that, but I try to take you through that step by step. So what we are starting with, we are starting from the in vitro system, and that's exactly what we described a minute ago. So we've got information about the intrinsic unbound clearance for the transporter of interest. It can be BCRP, it can be PGP, it can be whatever, any transporter for which you have information that your drug has affinity to. And that's something what we have just measured and analyzed in our in vitro experiments. So we start with this stuff here. As I said, we can use different cell lines, we can use different type of cells. It's a good idea to work with one single transporter at the same time, just to understand what will be its influence on the final exposure of this drug or drug candidates. Okay, so we've got a number here, 10 units, 15 units, 20 units, doesn't really matter at the moment, but it describes the clearance, how effectively the drug will be cleared, or how the system media will be cleared and the drug will be taken inside the cell for the uptake transporters. But we do want to take it far, far away from that to the brain level, okay? So with that, we have to make 3 steps. The first one is we have to scale it up to the level of the larger system. So we switch from one single cell or type of cells to the brain-specific type of cells. In this case, we use, and people use in general, human brain microvessels, because that's exactly where the situation happens, where the whole story takes place. So in those brain microvessels, transporters are located, and they do the uptake, which we have just described. So we do have to know how many of those human brain microvessels do we have. That's the first thing. And the second thing is, what is the difference in terms of the number or amount of the transporters in our in vitro system and in human brain microvessels? So the first scaling is, or first step, the first jump to the next level is to scaling based on the amount of the transporters. So for example, we've got 10 units of transporters, picomole of transporter X per milligram of protein, and we know what is the amount of certain transporters in microvessels. That's something what we have just discussed. So we are comparing these 2 systems between each other. It's like a ratio. So our system, like CACO2, has 5 or 0.3, and our SLC2A1 or GLUT1 has 60. So we're just scaling it by 30 if I calculate well. So that's the first simple scaling factor. It is called intersystem extrapolation factor, or ref factor. It's exactly the same depending how do we treat it. And with that, we are switching from our in vitro system to the still in vitro ex vivo. However, it's humanized. Okay. Then there is a second step. So we have to know what is the amount or number or mass of microvessels per gram of brain. And again, that's something that has been measured. Luckily, Japanese group, they had access to the human brains and they really measured this kind of stuff, which is absolutely fantastic. And we do this scaling. So from the intrinsic clearance at the level of the human brain microvessels, we switch to the gram of brain. So we're at the level of the gram of brain or brain tissue altogether, which consists of, apart from other things, from human brain microvessels. And then there is a third step. So we multiply it by the brain weight, which is individual. So we've got a relatively huge variability or significant variability here. There are variabilities at each and every step, which I'm describing at the moment. So both of these factors or parameters are variable, and there is a purely statistical variability on top of it. And the same here. So you can imagine that here we have one single value for a drug candidate for a transporter X. And then when we switch the intrinsic clearance for certain transporters, we've got a bunch of values depending on the value of these 3 scalars here. So from one value, we make hundreds, thousands, infinity, depending on the number of virtual individuals which we want to treat or test or simulate in a moment. So that's exactly how it is done. And it gives you the information about something what Karolina mentioned in the introduction, inter-individual variability. It's absolutely critical, and that's something what PBK allows you to do. Something what is relatively important from our perspective, at least. We do sometimes focus on partitioning only, which is fine, but it happens that we forget about the active transport. Whether partitioning is not only the passive diffusion, it's not only the passive partitioning, we do have to consider active transport as well. As long as we don't have active efflux or influx, this both phenomena which are present in this Frieden equation, that's fine. We just get rid of them in the equation. They're just zeros. And in such a case, our partitioning between the brain and plasma will depend on the passive diffusion only, plus flow of the blood through the brain. But we can't focus on the passive only in most cases. I will contradict what I'm just saying, because the first case study which I'm going to discuss is based on the passive diffusion assumption only. But well, it can happen, but it's not that often. What is important information here? Partition coefficient, which we often assume is a constant value, is really not a constant value. It's a dynamic parameter. It changes in time. Specifically when our drug has affinity to the transporters. So it will be like changing in time, as you can see here. So this partition coefficient, where UU stands for the unbound, unionized partition coefficient between the brain tissue and the plasma, changes in time because the activity, because the affinity changes in time. So that's something what we have to consider as well. It was an introduction. I threw it all on you, and now we go to the meat. Why are we even interested in the brain, and why brain is so important? Why brain is so complex and gives us so much fun and so much problems at the same time? Because it's huge. There are millions and millions of neurons. There are millions and millions of capillaries. Blood-brain barrier is huge. It's like a 15 square meter in average, about 7 square meter of BCSFB. So that's something that's really complicated. From my perspective, from our perspective, what is important are transporters there. There's a bunch of them. There are enzymes there. Brain is very active metabolically. So everything what I have just said about transporters and disposition will or can be transferred to the enzymatic reactions and enzymatic metabolism as well. So that's something what we cannot forget about too. All of that gives us the information about the complexity, and for us modelers, it's like a starting point of understanding what needs to be done. How does it look from the pharmacist perspective or medical doctor perspective? It's a biophase, so it's a place where fun happens or drug work, and we are interested in the concentration in the brain. However, as you know, again, probably very well, depending on the drug, the concentration of the biophase will be different. So it can be CSF concentration or cerebrospinal fluid concentration, which we're interested in, like for the I don't know, antibiotics, which we use during the brain infection, extracellular brain concentration, like narcotics. That's something what we're interested in because the receptors are located there. Intracellular brain concentration, so what happens inside the cell, inside neurons, corticosteroids, anti-cancer drugs, and so forth and so on. All of that gives us the information that we need, not necessarily like a one huge brain. We have to dissect it to parts, and we have to understand how the flow really happens there inside the brain. Okay, so I mentioned several times that what we do in our team is modeling and simulation. We don't do lab work. We're too lazy for that, and we've got 2 left hands. I promised a little bit of modeling. So far, I showed one equation, and that probably will be it. But let's start with modeling. So what is the simplest structure or simple description of the simplest structure of the brain? As I said, it's like a one compartment, one tank where we want to inject our drug, and to know what's happening there. It's not enough, as we agreed. Different drugs, different biophase, different concentrations. We do have to dissect this brain into the subparts. And here is one thing. There's one quotation which each and every modeler repeats like 3 times a day or 5 times a day. There is no perfect model, and never will be. Each and every model can be modified. Each and every model can be criticized. Each and every model can be changed depending on the need, depending on the data which we have. Same here. What I'm going to describe very quickly is a 5-compartmental brain model, but it doesn't mean it's the best structure or it's the only structure. Hell no, you can have as many compartments as you want. The problem is with the parameterization. So how to provide the data to describe this movement of the drug inside the brain. I said 5, but there are 4 squares right now. So the 5th one will be blood-brain. So we've got blood-brain, as I said. We've got spinal cerebrospinal fluid. We've got cranial cerebrospinal fluid. We've got intracellular fluid and interstitial fluid, and we separate them. Apart from that, we're interested in barriers. So I said there are 2 barriers, right? So the first one will be at the level of the brain and CSF, and the other one will be at the level, at the border between the blood and ISF. However, there's a third one as well inside the brain. It's a barrier between ISF and ICF, so intracellular fluid and interstitial fluid. Why there is a barrier there? Because there are transporters there. As long as there are transporters, they will be actively throwing drugs in both directions, so we do have to account for that. There is no barrier between the fluids. Fluid just flow, as you can imagine. Okay, let's try to parameterize this model. Let's try to put some numbers here without showing the numbers, actually. So let's start with the blood flow. So we know that the blood will be flowing through the brain, and sometimes, specifically in PBK world, blood flow is encoded by Q flow. And that's something what we have to know. So we have to provide the information to the system about how much of the blood flows through the brain per minute, per hour, per day, depending on what we need. We do have this data. We're lucky enough that people measured it. It can be relatively simply measured, and that's something what we have. The other thing which we need is a blood flow between the blood and cranial and ISF. It's not the blood per se, but more of a interstitial fluid or lymph or whatever, but there is a flow there, and we have to know that. The same actually occurs, and the same applies to the flow between all these left-hand side elements or compartments. Luckily, people do measure this kind of stuff. It can be measured by radio-labeled compounds, for example, or some other techniques. So we do know the values. We do know, we can really put the number behind those arrows. There's plethora of them, so don't ask me about the values, but we do know them, and we do have this kind of information. The same when it comes to the flow of fluid between the interstitial fluid and cranial CSF. Again, we do know this number. Then we switch from the fluid flow, it can be blood, it can be interstitial fluid, whatever, to the passive diffusion. So we've got clearance in and out when it comes to the drug of interest between blood and CSF. We've got clearance, which describes the movement of the drug or how effectively the drug is cleared from one system and transports to another. For these 2 friends here, ISF and blood. We've got exactly the same for the clearance between ICF and ISF. And again, all these parameters are not system parameters any longer. That's something what we do have to measure in the lab, or Carolina has to measure in her team in the lab and provide to the modelers for us to make us happy and to parameterize this model and to run the simulation. It's not over. There is a passive diffusion as well. This one was active. This one is passive diffusion. So we've got a passive diffusion between all different parameters, all different compartments here. At least 4 passive diffusion, let's say, data or clearances can be provided. As I mentioned previously, brain is metabolically active, so we can have metabolites and we can have a production and clearance of metabolite, which can come back to ISF from ICF and can be distributed everywhere in the brain. As I said previously, we've got two types of parameters: system and drug-related parameters. System parameters in most cases come from modelers. We're really good in looking for the data and talking to people to measure things for us, and they do that. So we do provide this kind of information. We do analyze the data and we do the meta-analysis. In general, we are pretty confident and we're able to provide whatever is available. Everything what is related to the drug or drug candidate is on your side, is on your shoulders. So you interested in new drug modalities, in new drugs, have to provide this kind of information. So clearance, active, clearance, passive, that's something what is on your side. And we do expect this kind of information from you. From the brain perspective and brain model perspective, we do have quite a lot of data actually. We've got information about the volumes of all of those compartments, which you can see here, flow rates, pH, because we've got KPUU, which is unbound, unionized. So we have to have pH to apply pKa on top of it to be able to calculate ionization. We know how much of the proteins is there, both enzymes and transporters, and we can make this model to be active transport-wise and metabolism-wise. What we don't have is clinical data, as you will see in a moment. There is very sparse information which would allow us to validate this model. I'm aware of literally 2 or 3 or maybe 4 case studies where people really measured and published about or on the concentration of the drugs in the brain. CSF being probably the most common one because it's relatively simple to probe, or relatively simple to probe as compared against the brain tissue or solid tissue. So the data is sparse and validation of this model is really sparse, which we have to be aware of, but it's not on us, it's on you experimentalists. Okay, the first case study then, paracetamol. Obviously works in the central nervous system, and we're interested in the concentration of paracetamol in the CNS to be able to predict what we can expect in terms of the pain killing effect from this drug, for example. For the beginning, I will contradict what I said like 15 minutes ago. I will focus on the passive diffusion only. So let's assume for a moment that paracetamol has no affinity to transporters. It will be distributed passively only. So we do have to provide, we as experimentalists interested in parameterizing this model and using this model, these 4 friends here, these 4 values here. Passive diffusion between these 4, say, barriers, if you like. That's something what can be done actually, because we can measure it, or we can calculate or intelligently assume some of them. So first of all, PSE, it's about 300 liters per hour. Why? Because that's pretty much what's the fluid flow between these 2 compartments or subcompartments of brain. So we can assume as long as the fluid flows actively and easily, there are no barriers, there's no hindrance from the barrier type of activity, the paracetamol can be distributed easily as well, or simply as well. All right. The second thing is ICF is about 80% and ISF is about 20% of the brain mass. So what we can say is we can measure only one of them, and with that assumption here, we can calculate the other. And that's exactly how people did it. So they measured PSB, which is about 2 liters per hour, or how effectively the drug is permeates passively only between the blood-brain and ISF, and then about multiplying by 4, calculated PSI. It's a little bit of cheating, I know, but it's an intelligent cheating, trust me. And that's something what we do have to live with, because nobody's measuring it. It's not that easy to measure the passive diffusion between these 2 subcompartments. What is left is PSC, so the distribution or diffusion between the cranial CSF and brain. Again, assumption based on understanding of the flow and structure of the barrier. It's half of PSB of this friend here. We've got everything what we need based on the assumption that it's only passive diffusion. All those red friends here, flows of fluids, comes from us modelers, because we found this information in the literature. We already parameterize the model with that. So we've got everything. All we have to do is to press the button and run the simulation. And now TV screen cooking. The results are here. Surprise, surprise. So what we have here, 4 compartments, plasma, so blood, depending on how do we define that. We've got cerebrospinal fluid, ICF, and CSF. As I said previously, we do not have, in most cases, information about the concentration in the solid brain, at least for human beings. I guess people do measure it for preclinical species, right? For rats, for monkeys, or some other in vivo models which we use. But for humans, as we are interested in here, it's not that simple. However, without any fitting, any optimization, any cheating, apart from what I have just said, we've got a prediction of this drug when it comes to the concentration. How does that change in time after single dose in the plasma and in the cerebrospinal fluid? So as you can see, it's great fit. So we are able to predict what we can expect there. How good we are for these 2 friends here, I've got no idea. I do trust my model, but I can't validate it. So I don't know how good or bad it is. Maybe the good idea would be to sacrifice or to take some rat data first, or to run experiments to understand what is going on in the rat, and then try to scale it up or extrapolate to human. Maybe that's one of the strategies. And so far, I don't know how to parameterize that. And in general, people don't know how to do that. What is important here, and please note, there is a difference in Tmax between plasma and cerebrospinal fluid. It's expected because there is a barrier here. So we expect that Tmax different, and that's something what we are able to predict, as you can see here. Okay. The CSF value has been predicted well. It's a measured data from a single study published several years ago. However, let's run virtual scenario. Let's assume for a moment that we are working on a drug which is paracetamol derivative or some combination of paracetamol with something, went for more chemically twisted or skewed colleagues, and they added something to the paracetamol structure. What made, apart from maybe other things like metabolism, one significant change or modification, it has affinity to PGP. Paracetamol doesn't have it. Our new drug candidate, which we're trying to make a better paracetamol, has affinity to PGP. Let's assume that we measure this affinity to PGP in vitro, and we know that the intrinsic clearance is like something about 20 microliters per minute per picomole of protein. And the question is, how will it change the behavior of this new drug or potential drug when it comes to the tissue concentration? In this case, we're still interested in the brain tissue. So what we have here are purely virtual scenarios testing. Again, it hasn't been validated because we don't have this kind of data. Nobody has done that, as far as I understand. It's purely to understand what can happen, virtual scenarios testing. And I think that's something what can be of significant and very practical use for some of you probably working on new drugs. So what can I expect in terms of the brain concentration when I change or modify the structure of the drug, right? Intrinsic clearance has to be measured. So that's something what we have to, go to the lab and make our hands dirty. However, that's something what it's done relatively commonly these days. And that's pretty much it, what we need, we modelers, to run the simulation and to try to predict what we can expect in the brain. So when there is no PGP or paracetamol, the concentration is like that, we change the concentration in the cerebrospinal fluid. We take it down, decrease it. Why? Because PGP is an efflux transporter. So it throws away from the epithelial cells to the blood again back. So the concentration of our drug candidate, potential drug, decreases as compared against the paracetamol. It can be the other way around, actually. We build a structural compound, a potential drug, which has affinity to the influx transporter. So the concentration will be higher because of the affinity to this transporter. How much higher? What will be the fold of difference? That's exactly what simulation can tell you. So we're not blindly looking for, guessing any longer. We can have quantitative metrics and quantitative understanding what we can expect when it comes to that drug after several changes, chemical changes, which you can see here. I mentioned this intracellular. I need like 3 or 4 minutes and I'm done, I promise. I mentioned this intracellular concentration because there is yet another case study which I want to go through very quickly. AZD1775 was tested for its anti-cancer activity. And it's been investigated to first penetrate the brain and has some activity and be used for oncological indications to be precise. It's a nice case study which was published again several years ago, but it's a good example of a, let's say, thinking which would allow us to understand what is going on when it comes to brain concentration. Why? Because they measured all the data. They knew in AstraZeneca that it can be important. They do use the system which I'm using to run the simulations, by the way. And they measured all this data. And based on this measured data and information about the affinity to certain transporters, we can parameterize the model and run the simulation, understand what is going on in the brain. All right. And then luckily for us, this drug was not successful, unfortunately, but we had a nice case study to parameterize the model and to test how good or bad it works. Okay. So what do we have and what is the strategy in general? We do consider that the blood-brain barrier is based on the, let's say, active activity or work of transporters. So we do have information about the affinity to certain transporters. They have been measured in 2 different experiments. Both of them didn't use cell-specific models. It was MDCK, which is a dog cell, heterogeneously transfected with several transporters. And at the end of the day, they measured this intrinsic clearance. And with that, we can use this data to put to the model and to predict what we can expect at the end of the day in terms of the concentration in the brain. There is, however, one thing and one caveat to that, and one, let's say, hole which we have to understand to not to fall. The quality of the data for 2 transporters was really good, PGP and BCRP. And we had really nice information about the intrinsic clearance for both of them. So we knew how they will work. Both of them are efflux transporters, and we're happy we run the simulation. And that's the result. So in terms of the plasma concentration is really good. This crosses our measured data, and the line is mean concentration plus 5th and 95th percentile. And the same for the ICF. And it's not great. We underpredict, and it's a really significant underprediction. There is something else going on. Coming back for a moment to the first slide of this series, as you can see, they say there is a potential involvement of ATP1A2, but they didn't measure it. We had no clue what is the affinity. So what is the intrinsic clearance, or IC50, however we measure it or describe it. We can just guess that there will be something there, okay? We didn't have good quality in vitro data. So what we did, what can be done in this case, again, cheating, but it's a scientific cheating, which we describe and confess. We do cheat in an intelligent way. So what do? We take the in vivo plasma data and we optimize mathematically using optimization algorithms what will be the intrinsic clearance value for this certain transporter to give us good prediction. That's exactly what we did. So instead of measuring this data, we guessed this data. And it seems that the efflux clearance will be at the level of 30 liters per hour. And that's exactly what we can expect to give us a good prediction. Whether it is true or not, I don't know. That's again on you guys. You don't have to measure it in vitro in your labs. However, that's what we modelers can help with. There is something what we are lacking. There is misprediction. We can tell you what is lacking. So the easy job is on your side right now. Just go to the lab and have fun with all these dishes and stuff. No, but seriously speaking, the message is there is no in vitro world. There is no lab world. There is no modelers world. We do have to work together, really. And that's something what I'm calling for. I've been calling for that for decades right now, which shows how old I am. But that's something what is lacking, really. Sometimes we do not understand each other. We speak different languages. We use different scientific dialects. Let's try to find a common ground. We can be useful for each other, and we can be useful for the potential patients for which we're working on at the end of the day. Okay, so once again, we cheated, but it was done purposely, I would say, and it helped to understand how AZD 1775 was supposed to work. It didn't eventually, but again, it moved the boundaries of understanding, or barrier of understanding a little bit farther. We know how to do how to deal with this kind of stuff. I hope I did not discourage you from talking to modelers, doing modeling and simulation, and providing the data for us. So please do that, and I'll be happy to take any questions which you may have. Thank you so much. It was a pleasure.